Welcome to the virtual Naloxone Train the Trainer course. Thank you for joining us. We look forward to hearing the successes of naloxone expansion in your area. My name is Lieutenant Commander Kristin Allmaras, and I am the Secretary for the IHS National Committee on Heroin, Opioids, and Pain Efforts, also known as the HOPE Committee. And my colleague, Commander Tana Triepke, our harm reduction lead, will also be joining us for this presentation. We have probably come together for various reasons, but we all have one overarching aim: to respond to the opioid epidemic. And today we are specifically increasing our knowledge and awareness as it relates to naloxone, the life-saving opioid overdose reversal agent. The growing concern for opioid overdose deaths can be seen across three waves. The first wave was a rise in prescription opioid overdose deaths, which started in 1999, depicted by the light purple line on our graph. The second wave was a rise in heroin overdose deaths, which started around 2010, shown as the orange line. And most recently, the third wave shows a rise in synthetic opioid overdose deaths, which is depicted as the dark colored line reaching to the top right corner of our chart. And combined, these three waves, in addition to barriers to care, have caused a dramatic increase in overall opioid overdose deaths dating back to the late 90s. When looking specifically at American Indian and Alaska Native communities, overdose deaths occur at twice the rate in these communities compared to the general US population. In 2017, they had the second highest overdose rates from all opioids, the second highest overdose death rates from heroin, and the third highest from synthetic opioids. Opioids are a class of medications that include heroin, morphine, codeine, oxycodone, and the others listed on the slide. There are many slang terms that are used to refer to opioids, like oxy, perks, smack, junk. And if we were delivering this presentation in person, I would almost guarantee an audience member would be able to provide additional slang term examples that they have heard in the field. There has also been a recent rise in fentanyl use and related overdoses. Fentanyl is particularly risky because of its potency. It is 50 to 100 times more potent than morphine. Opioid overdose is a condition when an excessive amount of opioid is swallowed, inhaled, injected, or absorbed through the skin, which can all be intentional or unintentional, and leads to slowed breathing and possibly death. Let's walk through the overdose process. How exactly does this happen? The process takes time and it varies from person to person. Initially, one's breathing will slow. This is because the opioids are suppressing one's urge to breathe. Then, breathing will stop. Carbon dioxide levels will increase in the body and oxygen levels will decrease. This lack of oxygen can result in brain damage if the individual is successfully resuscitated. If the individual is not successfully resuscitated, the heart will eventually stop and death will occur. The key take-home message is that there is time to respond. There is time to save a life, but you have no time to waste either. So we want to be able to recognize an overdose quickly and be able to respond in an efficient manner. So how do we identify an overdose? The common signs of an opioid overdose are slowed or shallowed breathing, finding an unresponsive person, or if that individual is difficult to wake, a slowed heart rate, low blood pressure, pinpoint pupils, gurgling, blue lips or fingers, and cold or clammy skin. The disease of addiction does not discriminate, nor does the potential for an opioid overdose. It can happen to anyone. But there are people who are at a higher risk for an overdose, including those who recently underwent opioid detoxification or were recently released from incarceration, those who use drugs via IV injection, those who use high-dose opioid medications, which can be prescribed or unprescribed opioids, those who use opioids with other medications or substances that cause drowsiness, like alcohol or benzodiazepines, such as alprazolam or diazepam, those who have a history of substance use disorder, and those who also have underlying health conditions, such as asthma, COPD, kidney disease, and are elderly. So how can you help? One successful harm reduction strategy to employ is the widespread use and acceptance of naloxone throughout your facility and community. Naloxone is a life-saving opioid overdose reversal agent. As described in the picture, opioids sit on a chair or a receptor in the brain, and when these are full or saturated, the opioids cause an overdose. Naloxone comes in and sits or binds to the chair or receptor and kicks off that opioid. This results in an overdose reversal. Keep in mind, depending on how much opioid is in the body, one may require multiple doses of naloxone. And depending on what type of opioid is in the body and its respective half-life, one may be revived and slip back into an overdose state if the naloxone wears off before the long-acting opioid. In both of these instances, one may have to administer multiple doses of naloxone. Naloxone is a prescription medication that can temporarily reverse the effects of an opioid overdose and prevent death. If you find someone who fits the signs and symptoms of an overdose, it is better to give naloxone than to withhold it. If given to a person with no opioids in the brain, there will be no effect. So you will not hurt someone if they are not taking opioids. Because there is no risk, it is always better to give naloxone if you are able. It will typically start working in 1 to 3 minutes, and naloxone can last up to 30 to 90 minutes. It cannot be abused to get high, and repeated doses will not cause tolerance. So there's no concern for reduced efficacy in someone who has been revived multiple times. As mentioned before, the amount of naloxone needed will depend on what opioid and how much of the opioid has been taken. Naloxone will reverse opioids, which includes heroin in the examples we provided earlier in the presentation. It will not reverse cocaine, methamphetamines, benzodiazepines, such as diazepam or alprazolam, and it will not reverse alcohol.
First, we will review the naloxone nasal spray device. To use the Narcan nasal spray, you will remove the naloxone from the box. There are 2 separate nasal spray devices in each box. Peel back the tab with the circle at the right-hand corner to open. Hold the naloxone with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers are against the bottom of the person's nose. Press the plunger firmly to deliver the dose of naloxone. If the person does not respond by breathing normally, continue rescue breathing if trained to do so. Repeat every 2 to 3 minutes until the person is breathing on their own. Place the repeated doses in the opposite nostril when possible. Continue to monitor the person until emergency responders arrive. Remember 3 simple steps: peel, place, and press. These pictures show what each individual nasal spray device looks like within the box of Narcan. The box contains 2 of these nasal devices, and the arrow in the center indicates where to peel open the device. Keep the naloxone nasal spray sealed until needed for an emergency. The other formulation of naloxone that you may come across is the intramuscular injection. This either comes in a vial or a prefilled syringe. To use the prefilled syringe, you will remove the protective caps from the vial and injector. Then you will thread the vial into the injector 3 half turns or until the stopper is pierced. Next, you will remove the cover and expel the air before injection. Lastly, the needle needs to be attached to the syringe. Inject the dose of naloxone at a 90-degree angle in the upper arm muscle or thigh. For the vial, you will need to remove the cap first. Flip the vial upside down and insert the needle through the rubber plug. Pull back the plunger until 1 ml of naloxone is drawn up. Then inject into the muscle of the upper arm or thigh at a 90-degree angle. This slide highlights the next steps in the emergency response. You will check for breathing, call 911, perform rescue breaths if trained to do so, prepare your naloxone, and then evaluate the response and provide support. Let's go into further detail of this process. Upon finding someone unresponsive or not breathing, you will activate 911. Check for signs of an overdose, such as blue lips or fingertips, irregular breathing or gasping. Provide rescue breaths if CPR certified. To further break down rescue breathing, you will verify if the airway is clear, perform the head tilt, chin lift, and pinch the nose closed. Perform 2 rescue breaths and repeat 1 breath every 5 seconds for 1 minute. To protect yourself, you will want to use a barrier device to perform rescue breaths. Then you will administer naloxone and continue rescue breathing. Place the person in the recovery position when independent breathing begins. Transfer them to emergency care to be monitored because it is possible that they can overdose again. Naloxone lasts for 30 to 90 minutes depending on the route it is given. If the opiate in the body lasts longer, naloxone may need to be repeated every 20 to 60 minutes to maintain the overdose reversal. After naloxone is administered, it will put the person into an immediate state of withdrawal. The symptoms may include agitation, nausea and vomiting, excessive sweating, runny or bloody nose, rapid heartbeat, or high blood pressure. Prior to responding to an emergency, first responders shall use universal precautions and protect themselves by using gloves and barrier devices. Be aware of potential harmful weapons or drug paraphernalia such as needles. Interview witnesses regarding drug use when applicable. If an overdose is suspected, administer naloxone to the patient. How can you get naloxone? You can present to your local Indian Health Service facility. Anyone can come to the pharmacy to receive naloxone for personal use. Bring your expired, used, or damaged naloxone kits to the pharmacy to be replaced. Here is a list of do's and don'ts. Do support breathing by performing rescue breaths. Do put the person in the recovery position. Do stay with the person and keep them warm. Also, perform a stromal rub or gently pinch the person, but do not forcefully stimulate them or put them in cold water. Don't inject them with any substance, and don't try to make the person vomit. Why should you carry naloxone? It saves lives, and delaying use can lead to injury or death. Every second counts, and it takes time for emergency medical technicians to arrive on the scene. Naloxone use by first responders is standard across the country, and no negative health outcomes have been reported after 40 years of use. Good Samaritan laws are in place in the majority of states in the US, and they protect anyone who is responding to an overdose from prosecution in the court of law. Many tribes have amended their codes to provide good faith immunity to encourage bystanders to call for emergency help in the event of an overdose.
Now we are going to review some best and promising practices for you to take back to your facility and community. In order to expand access to naloxone, consider additional first responder training and ensure distribution of naloxone to first responders. Train the trainer. This is what we are doing right now. We are training you to go back to your facility and your community to spread knowledge about naloxone, increase access to the opioid overdose reversal agent, and increase awareness related to the risks of opioid overdose. Collaborate with community programs to offer training presentations that increase awareness and knowledge of opioid overdoses and naloxone. Allowing anyone to request naloxone from the pharmacy, so a friend or family member of a person who uses opioids can keep naloxone on hand. Another successful, promising practice is to establish comprehensive standing orders at your facility, allowing pharmacists or nurses to educate and order naloxone. This teamwork improves post-overdose care coordination and increases the opportunities for screening, brief interventions, and referral to treatment. Most recently, there are some considerations to keep in mind as it relates to the COVID-19 pandemic. Community resaturation may be needed after programs have closed their doors, and we're asking you to get creative. Get creative when trying to reach your community members. Consider drive-through events, virtual messaging, and even virtual trainings. We want to leave you with some concepts to remember. Addiction is a disease, not a choice. The road to addiction and journey to recovery is different for everyone. Harm reduction is a strategy that focuses on reducing risk of harm to yourself and others. This includes a variety of strategies from using medications to treat opioid use disorder, creating linkages between persons with substance use disorder and their friends and family to community education programs, as well as exploring opportunities to start or expand syringe exchange programs. Simply providing education on reducing one's risk by using less or using less frequently is a successful harm reduction strategy. And expanding access to naloxone is also an effective harm reduction strategy. As we wrap up our training, we challenge you, become an advocate for naloxone in your community. Become familiar with resources available in your area and online. The HOPE Committee has a naloxone training toolkit in addition to many other resources on their website. If you want to do this and don't know where to start, contact a naloxone mentor in your area. And again, don't be afraid to get creative. Think outside the box. Educate those who will listen and provide naloxone when able. If you are considering organizing a training, ask yourself, are you training more trainers? Point them to this virtual on-demand course. Coordinate your own Train the Trainer session and present this PowerPoint. This results in trained persons that can continue to train others. Or ask yourself, are you training community members, healthcare professionals, or first responders? Ask them if they want to be official trainers. If so, go back to the first question. Or you can coordinate your own session and present one of two PowerPoints that the HOPE Committee offers online, the community members PowerPoint or the healthcare personnel and first responders PowerPoint. And our final challenge for the day is that we challenge you to be the change you want to see in your community. Please reach out to myself or Commander Triepke if you have any additional questions or comments for today.